Good morning, everybody. Welcome you to Singapore, and luckily that the weather nowadays is fine in this area. First, I would like to thank the organizing committee who gave me this opportunity to meet with all of you so that we'll have exchange of knowledge and expertise from different cultures, from different communities. I'm going to talk about pure clinical aspect after the wonderful lecture of Dr. Sheikh about genetics and the future of it. Now we are back to the clinical practice. And as a pediatric intensivist, we know that infectious diseases are representing significant proportion of the admissions of pediatric intensive care units in general, and specifically viral infections, especially in the winter months, are representing a huge burden to the healthcare systems, I think worldwide, not only localized to our area. This is my hospital campus located in Abu Dhabi, United Arab Emirates. It is the most recent and the biggest tertiary care center within United Arab Emirates. I have no conflict of interest to disclose in relation to the whole presentation. And this is the items of the agenda that we will go through it. Actually, this was all of us, we know that viral infections are representing a significant cause of morbidity and mortality among pediatric patients who are being admitted to the pediatric intensive care units. They might progress into severe illness, and even many might end with death. And it has been estimated that the prevalence of PICU admissions due to viral respiratory tract infections is reported to be around 17% up to 20%. If you look for this figure across the year, across the whole world, this is a significant proportion, of course, of admissions to a pediatric ICU. Hence, our idea was that exploring the various viruses that cause PICU admissions might help in understanding the local epidemiology and planning the healthcare resources. The best example for this statement, what happened with the COVID-19. COVID-19, all the world suffered the limitation of resources of healthcare services to patients. And this is of particular importance during the seasonal crisis, not only COVID-19, also we have seasonal crisis, and some countries have some endemic crisis as well. During the COVID-19, the pandemic expanded, and the fear of burdening the healthcare facilities was significant for both patients and the healthcare authorities. And this was not only limited to the limited resource countries, but also worldwide. We saw in Europe, in USA, in Africa, in Asia, worldwide, there was a panic and very limited resources for the patients. Actually, it was this topic from retrospective cohort study analysis that had been conducted while I was working in Saudi Arabia at King Khalid University Hospital, King's University Medical City. In Saudi Arabia, the age cut limit for pediatrics was still 14 years, so we included all patients up to the age of 14, admitted from June 12-15 up to 12-18, who had been admitted to the PICU with a viral infection. And we got this period because Saudi Arabia suffered a lot about MERS-CoV. Before many years before the corona, Saudi Arabia was endemic and suffered a lot about MERS-CoV. We had defined the diagnosis of viral infection as any positive evidence of virus presence in the human body samples, detected either by immunofluorescence, which is being done by point-of-care test in the emergency departments, or by PCR tests after admission and the presence of symptoms supportive of the corresponding viral disease. The viral testing was performed based on the clinical indication of PICU team assessment, where the initial virus screening, if it was positive, nothing is going to be done anymore, but if it is negative, and the clinical presentation suggesting viral infection, we were proceeding for viral PCR, multiplex PCR. For bacterial co-infection, we reported the results of initial cultures that was done after admission to the PICU, because many of the viruses could not only be just a viral illness, but also co-infection with bacterial pathogen is there. For the label of sepsis, we use the international definition criteria for surviving sepsis campaign guidelines as a definition of sepsis. And we went for the standard routine statistical data analysis for our data collected. This table, our results, the total number of PICU admissions was around 1,736, including 164 representing around 9.45% proven to be of viral pathogen, and almost 10% of our admissions have been documented and proved to be due to viral illness. And this is the annual incidence, and through this figure we observed a little bit decline in the incidence or in the prevalence of viral infections in 2018 compared to the first year of data collection, 2016. We attributed that to many possible reasons. Part of it is improving of the hygiene during the Moscow. Some strict all hygiene precautions had been taken very well, so that by years things started to be less prevalent. And our data also had shown that the different viruses that we had identified throughout our period of study. As you see here, per month, the prevalence was significantly high in January, February, March, also November and December. And this is as what had been reported worldwide. Winter months are usually characterized by viral prevalence. This table is showing us our demographic data of our studied patients. Just for mentioning some significance, mild significance was observed among those who had received. This table is showing us comparison between patients who required non-invasive ventilation and those who required conventional ventilation. We know majority of the respiratory illnesses, viral illnesses are being mainly complicated by respiratory. However, some with cardiac, some with CNS or encephalitis, and some even with liver failure, especially influenza a few years before. So we have significant that babies with higher weight or height were needed conventional and high frequency mechanical ventilation. And they definitely, once they needed mechanical ventilation, their expected length of stay will be higher than those who just require non-invasive ventilation. And the same also pediatric index of mortality too was higher among those who required mechanical ventilation. And this makes sense because they are more sicker. The association of comorbidity. By comorbidity, we mean presence of any underlying chronic illness like congenital heart, cerebral palsy patients, gastroesophageal reflux disease, global developmental delay, cerebral palsy. We found that those who had some associated comorbidities required mechanical ventilation, either conventional or high frequency, compared to those who has no comorbidities. And this is important for us as a clinician so that we can address the expected length of stay even upon admission of the child based on that information. We did a multivariate logistic regression analysis of the viral infected PICU patients, association with the intubation and the mechanical ventilation, just to check what could be the real contributing factors that lead to conventional mechanical ventilation. Definitely length of stay, as we mentioned, was, and we didn't find any significance in relation to the sex, the age, the body mass index, whether they had presented with respiratory failure or they progressed to it after that, and even the associated comorbidity as a contributing factor with significance was not shown in the multivariate regression analysis. We did comparison between patients who had a single viral infection and those who has multiple viruses. As we know, the viral PCR multiplex can show us is a screening PCR for many viruses. So, and many patients could have more than one virus at the same time, as being detected by the PCR. We found that patients with multiple viruses had their age was to some extent older than those who has a single virus. Also, presence of comorbidity was more significant among those who has multiple viruses, and definitely the length of stay was also higher in those with multiple viruses compared to those who has single virus. And at the end, we did comparison between those who survived it and those who expired or died. Again, the age was significantly higher among those who died, and we could not find specific contribution for the age per se. Some other factors are there. They could be having more comorbidities, more chronic illnesses that could be ended with that. And again, presence of sepsis and acute respiratory failure had shown significant impact on those who died. So those who had been admitted with sepsis, as well as respiratory failure, in terms of death, it was higher among them. Also, the affected body system, it didn't show too much significance, whether CNS, cardiovascular, hematologic, or other organ system infection. And even the presence of bacterial co-infection, it didn't show any significant difference among those who survived versus those who died. When we will come to post-COVID, just wanted to compare what is the viral pattern, viral infection pattern being admitted to the ICU pre-COVID and post-COVID. As we see here, this is starting from April 2016 until the start of COVID. The yellow color, the blue color is showing us our rhinovirus. And the majority of the years, rhinovirus, along with adenovirus, human coronavirus, and definitely RSV, were showing significant prevalence before COVID. At the start of the COVID pandemic, as we see in October 19, still was rhinovirus was there and started to decline with more prevalence of the SARS-CoV-2 or the COVID-19 virus infection. So after COVID pandemic, the pattern and the times of pediatric viral infections resulting in PICU admissions had been changed significantly. This figure is just to show us what I was telling now, as we see how much decline in the blue color and how much rise after COVID-19. Pre-COVID and after COVID decline significantly. This is another publication that showed the pattern proportion of respiratory viral pathogens pre-pandemic and during the pandemic. I mean the COVID-19 pandemic. We see significant decline and increase in the COVID-19 and the viral co-infection with RSV. We know that RSV is and adenoviruses are significantly predominant in pediatric patients. However, pre-pandemic was high, post-pandemic started to come down compared to pre-pandemic. Human papilloma. sorry, human metapneumovirus. It is highly stable. I will look for it. This is another publication that was published in 2024 to show us, it was a Chinese study, to show us the differences in the patterns and viruses comparing pre-pandemic and post-pandemic, and all had been declined pre and post-pandemic. So in conclusion, we can see that respiratory viral infections are responsible for significant PICU admission days with high demand for mechanical ventilation. And patients with multiple viral infections had longer PICU lengths of stay, higher median PIM score 2, and more comorbidities. While previous research indicated that few cases of Middle East respiratory syndrome coronavirus in children were observed, it remains maybe a disease of adults, similar to what we observed in the COVID-19 pandemic. Few children still can encounter severe course with poor outcome in either MERS-CoV or COVID-19 patients hospitalized with comorbidities. Similarly, while common respiratory viruses cause a life-limiting disease in children, it can still result in many PICU admissions. And the downward trend of PICU admissions for viral infections between the end of MERS-CoV and the start of the COVID-19 could be through provoking the possible viral interference that warrants further investigations. Reports suggested that potential viral interference between COVID-19 and other respiratory viruses could be mediated by direct factors such as cross-reactivity or indirect factors, including changing personal behavior or public health interventions. This showed us or demonstrated the importance of planning of public health policy implementation during the seasonal months of viral infections to account for high PICU resource needs for these children. Again, we mentioned about the annual decline, and this is a list of my references. And lastly, thank you.